and people are still dying of COVID every day, but we could not possibly have a better speaker for today's topic than Dr. Sira Sikandar Madad. Born in the United States in October 1986, she grew up in New York's Long Island. Only 35 now, she's clearly a woman with a mission. She is an investigator and innovator, senior director of Special Pathogens Program, and a lead investigator at the Institute for Diseases and Disaster Management in New York for diseases like Ebola, Zika, and COVID. She's an outstanding communicator and educator, featured in award-winning documentary series on the pandemic on Netflix and on the Discovery Channel. The Netflix program, I note, was in fact completed even before COVID was fully upon us. At Harvard, she leads a seminar series on women in STEM, science and technology, engineering and math, and she also teaches at Boston University. She was just appointed to a US National Science Advisory Board for biosecurity. The motto at the university where Dr. Madad took her PhD in health sciences is engage, inspire, achieve. And I think you'll all agree, she's certainly been doing that. She took her PhD at Nova Southeastern University, a noted research leader, in 2014. At the University of Maryland, she did a master's in science on biodefense and biosecurity. She did her BSc in psychology. She's a working mom of 3, a child of immigrant parents, and clearly the right person to be addressing today's topic. And we're so grateful to you, Dr. Madad, for sharing your time with us today. So over to you for your presentation.
Thank you so much, Margaret, for that really kind introduction and so for those really, really sweet words. So thank you so much. It's a pleasure to be here with you all this evening, depending on where you are in the world, this morning, this evening, or this afternoon. Today certainly is an important day, in the year as we celebrate International Women, all the achievements that women have done historically, presently, and what's going to continue to happen in the future. And as we know about the COVID-19 pandemic, it has exacerbated so many issues and challenges around the world. And as it relates to women, there have been many different challenges, and the impact has been pretty significant. And it really just depends on where you are, in what country, in what region. You can feel the effects in multiple different ways. And so today, I hope to highlight many different things. And the first is that the impact is real, and that there are many challenges and issues ahead that we need to continue to rectify, and that we need to first acknowledge, and then make sure that we have a plan of action, and that we do mobilize. There are many different types of challenges, and I'm not going to get into all of them, but I will try to shed light on some of the most key challenges that I have found throughout this pandemic as it impacts women, and particularly in the Middle East. And so I'll shed some light on that. As I begin my presentation, the one thing that I'll note is that we are still in the middle of the pandemic. The pandemic is not over. It doesn't matter where you are, even here in the United States, as I sit here today, there are conversations of COVID being endemic and living with this virus, which certainly is true, but we cannot say that this pandemic is over here if it's not over all around the world. And so when we talk about the impact this pandemic has had on women, we can look at the interim reports. We can look at what has happened last year in 2020 and 2021 and get a sense of where we are going and, what we need to do. But by and large, it certainly is not over. And I do hope that once this pandemic is over, that we do have much more concise data. We have many more reports that shed light on the significant impact that this pandemic has had on women, and especially seeing what action items are going to occur at the international level as well as at the national level. I think the other thing that I'll just mention before I continue on with my presentation is that when we look at the recovery phase of this pandemic, and each country is going to be, on the track of recovery at one point or another, I really do hope that we look at this recovery phase as an opportunity to see the lessons learned and again make the change that we need to see today and tomorrow. The fallout from the pandemic and its impact on livelihoods on women has been pretty significant. And as we look and take a peek at each country, there are many different challenges that you're going to see. The challenges here in the US may be a little bit different than the challenges we may see in the Middle East, but they are challenges nonetheless, and we need to make sure that we understand them, that we acknowledge them, and that we do actually do something about them. So in my presentation, I'm going to highlight a couple of different data points, and this is by no means, giving you the total picture of the impact this pandemic has had on women, but I do want to shed light on some key data points that I think are just really important, that I certainly speak out to me, especially in the field that I'm in, when it comes to infectious diseases, when it comes to global public health, and what it means to be a woman. As we know, women face a number of different challenges, and I'm going to highlight momentarily. But as we look at the public health landscape, this is a report from 2020. And what it shows is that less than 30% of public health leaders are women. And it gives you 5 different things to note in a report that was published in 2020 by Global Health 50/50. And as you know, while women comprise majority of health and social workforce, they make up less than 30% of leaders in public health. As well as we translate public health to healthcare delivery, where patients present, you see that the majority of the workforce are also women, but they're disproportionately, less when it comes to leadership positions. And so when we look at this particular report, a couple of things I think that certainly call out to me. So first is that more than 70% of leaders in global health system are men. Less than 20% of leaders in global health sector are nationals of low income countries. And that's really important because as we look at the global health landscape, and in another slide that I'll show you, majority of leaders are actually from high income countries, yet they're obviously are doing work in low income countries. So we need to have much better representation. Only 28% of senior management teams have reached gender parity, up to 25% in 2018. At that rate, gender parity won't be reached in senior management at global health organizations until 2074. So that's a huge timeline. And again, we need to make sure we condense that. So if we acknowledge that these are issues that exist and that we need to do something about it, and there's commitment, then we need to certainly condense that timeline and not have it be stretched out to 2074. From 2018 to 2020, the total number of female CEOs grew by only 1, from 41 to 42, when it comes to some of these major global health organizations. And lastly, and this is, I think, just really right on in number 5, this isn't merely a result of slow turnover at the top. The report says, on average, 1 in 5 organizations under review welcome a new CEO each year. Simply, men continue to be succeeded by other men. And that is something that we certainly need to change. So as we look at this global health landscape, there is still a lot more work that needs to be done. And as we look at some of the reasons why, you see men in more leadership positions, you're going to see some of the challenges that women tend to have, and that we need to make sure that we rectify these challenges and remove these barriers. And I'm going to highlight some of those in my subsequent slides. This is a slide that I just alluded to, and this is actually an updated version, the 2021 report from Global Health 50/50. And what they're showing is that from some of the major global health organizations, out of 387 CEOs, 271 are men, 116 are women. But then if you actually look at, the actual representation, you're seeing majority, about 84% of the 71 men are from high-income countries. So again, as we look at the global health landscape, there needs to be much better representation of these organizations, of these countries in these organizations. And then similarly for women, 83% are nationals of high-income countries, and very small percentage, as you see, 5% are nationals of low-middle-income countries, and completed their highest education in lower middle income countries. So as we look at making sure that we fill many of these gaps and we rectify many of these challenges, it needs to be much better representation, much more diversity, and better representation of women in this landscape. And so as we look at, some of the impact this COVID-19 pandemic has had on the woman workforce, you're seeing, just certain estimates. And so for this one in particular, from the McKenzie Report, you're seeing a significant setback. And what it shows is that the COVID-19 crisis has driven as many as 2 million women, particularly mothers with young children, to consider leaving the workforce or stepping back from their careers. Now, this is pretty significant. And again, this is just an interim report. So as we look at the total impact this pandemic has had and will continue to have, both in the immediate and the long term, it's going to be quite significant. So it's really important that we acknowledge that there's going to be a setback, that they're seeing a mass exodus of women from the workforce. And what does that mean to the economy? What does that mean to our social structure? And making sure that we remove the barriers that exist. And by no surprise, we can predict what are some of these barriers. And so one barrier, as you may know, is childcare. And this is a report that recently came out that Becker's Hospital Review shared here in the United States, and it's showing that 34 states where childcare costs more than college tuition, right? So just here in the United States, and I'm sure as we look at the international landscape, childcare services and the cost of childcare is quite significant, and it is a significant barrier of women continuing to work and trying to find these childcare services. So in this particular report, it shows that the burden that mothers often have in providing childcare support and choosing between work or being home with their child, because of the cost of childcare services. So it shows in this report, mothers continue to shoulder the majority of family, caring for family and the responsibilities, making childcare a heavier tip of the scale for healthcare. And as we know, as I mentioned and I alluded to earlier, women make the majority when it comes to frontline workforce, particularly here in the United States, as well as all around the world. You're seeing that women, by and large, in healthcare, are make the majority, and yet when we look at some of the barriers and the impact, is quite significant. So in this slide, what I've just done is I've put together a number of different challenges and issues that I have seen across the landscape in the Middle East. And this will vary from each region and each country, but it really shows you some of the challenges and impacts that the COVID-19 pandemic has had and continues to have on women. So the first, it shows, women in my previous slide, shouldering a burden of homeschooling, taking care of sick and the elderly. And that certainly has an impact, of them leaving the workforce and having to obviously spend more time at home and not, in the workforce, and making sure we address some of those issues. Higher impact to low wage jobs, informal workers occupied by women workforce. As we know, women unfortunately, make up a large portion of low wage jobs and informal workers. And as we look at the COVID-19 pandemic, that has been one of the categories of work that has been significantly impacted. The economic fallout from this particular crisis. So, there's been a lot of work that's been going on and continues to happen to close the wage gap and to ensure that there's gains in wages, and so that certainly has taken an impact in this pandemic. The diversion of funds to combat the pandemic, which has taken away from other essential services to women, such as sexual and reproductive services. So, because of lockdowns and shutdowns and services not being available, or funding being diverted to combat the pandemic, some of these essential services that are provided to women have been taking a back seat, and it's been pretty significant in many of these countries. There's also less access to savings and health insurance when it comes to women. And so when we talk about this pandemic, you're seeing that because, of issues in the, with employment, many don't have savings. And then when it comes to health insurance, especially in many of these countries, for example, here in the United States, we still have millions of people that don't have health insurance. And that certainly is an impediment to actually seeking healthcare services and getting the care that they need. There's further marginalization and exclusion from the workplace when it comes to women. There's more burnout, fatigue, and exhaustion. So in fact, if you're seeing certain, certain reports, particularly here in the United States, many new reports coming out showing the overall burnout being much more significant in the women workforce than it is in men. There's also less access to computers and internet access. And as we know, in this COVID-19 pandemic, when things started to shift online, women, unfortunately, in many of these countries, have less access to computers than men. And so they're not able to seek, good information when it comes to this pandemic. So when we talk about public health guidance and what to do and how to protect yourself, they may not have access to it right away, which can put them at higher risk, for contracting the virus, as well as not seeking healthcare services in a timely fashion. There's also gender impact, obviously, on labor workforce participation, so less impact of women, on the labor workforce because of this COVID-19 pandemic, less opportunities for women for employment and discrimination in the labor market, erosion of social protection, exacerbating the poverty line, and the list kind of goes on and on. But a couple that I just want to also just, call out is the increase in gender-based violence. And I think one thing to note is that the absence of data doesn't mean that there isn't an increase in a certain impact. And when we talk about domestic violence and just violence in general and abuse, we've also seen that here in the US as well as in other countries where, you may not get calls or reports or people coming in to shelters because of the COVID-19 pandemic. That doesn't mean that, there isn't an increase in violence. In fact, we have seen reports where, particularly here in New York, where I am, you've seen a significant lower volume of calls that came in, less women coming into shelters or seeking support from domestic violence. And that's not to say that they weren't experiencing it. In fact, it was almost double what they were experiencing, unfortunately. But because of the pandemic, you just couldn't see that. It was hidden, unfortunately. There's also greater risk of exploitation of migrants and refugees that are women because of the COVID-19 pandemic and the impact that's had. And then women tend to juggle a lot. We tend to multitask, but when it comes to multiple other crises, when it comes to displacement, what's happening in Ukraine, civil unrest, and so many other issues, they tend to have to bode and juggle all of them all at once. So the impact of the pandemic has been significant, has been dire. There's so many different stats, there's so many different reports out there that highlight in multiple different countries, what is happening and what we need to do to close this gap when it comes to gender disparity, the disproportionate impact women have on this COVID-19 pandemic. So there's a lot of work that needs to be done. And certainly I look forward to the conversation we're going to have in terms of looking at what can we do both in the immediate, the immediate goals and then long-term goals, and how we can develop additional partnerships to close many of these gaps and address many of these challenges. So with that, I'm happy to turn it back over to Margaret to talk a little bit about, next steps and challenges and how to put some solutions to them.
Thank you so much. You covered such a lot of ground in a very short time. And many of the questions that I had in my mind regarding today's topic, but it was particularly striking when you spoke about the lack of women in leadership positions in public health. And I think in Canada, we're somewhat lulled about this because so many of the key public health officers at the provincial level in British Columbia and Ontario and elsewhere have been women. So we overlook the fact that our hospital systems, major CEO positions, etc., are, overwhelmingly male. So the question is, what advice would you have for young women who are thinking of entering the public health field?
Yeah, it's an excellent question. In particular, when it comes to public health, women are actually make up the majority of the workforce also in public health as they do in healthcare, but very similarly don't hold as many leadership positions. And I think it's really important that we do challenge the status quo. So these are man-made challenges, right? Or human-made challenges, if you will. So when we look at the discrimination, the disproportionate impact, when we look at many of these disparities, because they are made by people that can be changed. And so if we have, women that stand up and know their value, it's really important that they speak up. Being in public health myself, oftentimes, when I work in the field of emergency management or emergency response, by and large, I see there's many more men than they are women. But I always try to make an opportunity for myself to voice, my feedback, my suggestions, because when we talk about developing policies or putting guidances together, it's really important that we have a woman voice in it that can speak to, the issues that we deal with, that we can relate to, that we can build better policies that can actually be sustained and be followed. So I would just empower, our youth as well as women in these types of positions to speak up and to know their value and to make sure that they are part of these conversations.
I think as we encourage our audience, our participants to pose questions in the Q&A box, one related question to the last points you touched on, you referred to the fact that COVID deaths vary so much by race, community, social factors. To what extent do they vary by gender? But in all of these areas, how can we positively speed changes in organizations on addressing these differences that can have such varying impact?
Yeah, so when we talk about the COVID-19 pandemic, and as we look at the impact it's had by gender, by race, by ethnicity, certainly you're seeing, disproportionate impact in many different races. So particularly here in the United States, for example, it's by no surprise that you're seeing, a larger impact on people of color. And as we look at it by, different races, as we look at it by gender, there certainly are, challenges, there certainly are, issues that we have seen that we need to make sure that we rectify. When it comes to organizational change, I think the first thing that we often need to do is make sure that we acknowledge, as I mentioned, that there is a problem, that there is a commitment, and that we build policies around it. Because policies is something that I think you can measure, that you can, that you can evaluate an organization against. So if they are developing a policy where they're looking at gender, they're looking at equity, they're looking at diversity and inclusion, you can hold an organization accountable for that. So making sure that we're building policies with those key principles in mind, I think is really, really important.
In a related question, which comes from Aisha Mallet, who is the new president of the Canadian International Council's National Capital Branch and a executive at Global Affairs Canada, she asks, how do intersectional factors, race in particular, play a role in the way women are represented in leadership positions within the public health field?
Yeah, so here in the United States, you're seeing more white women being overly represented in public health versus those that are, women of color. And in fact, when you break it down by age, you're seeing more older white women, taking, positions in the public health workforce. So I think that speaks to ensuring that we have much more better diversity. And I think as we look at some of the lessons learned from this pandemic, you see that it's really, really important to have community engagement. And when we talk about community engagement, it's making sure that you're bringing in people that look like the people that they're serving. So in particular, when we talk about, for example, my mother, English is her second language. She doesn't speak English all that well. And so during the height of the COVID-19 pandemic early on, when we talk about contact tracers, trying to contact her to let her know she may be exposed, it was a person that was white that came to her door and knocked. And so she didn't want to open the door. She didn't know who it was. She couldn't really understand what they were saying. And even though they gave her information of what to do and where to get tested, she wasn't sure if she should trust this person. But if that same person was somebody that looked like her, that maybe was another woman, she may have been able to relate more. She probably could have understood more of what they were saying, and could have made a much bigger impact in this pandemic. And so when we look at representation of women in public health, I think it's really, really important that we bring diversity into this workforce, because it's not just for this crisis, it's going to be all the other crises that we're going to face in the future. And we know there's going to be additional crisis, whether it's a public health emergency because of an infectious disease event, or something like an all hazard type of event where it's hurricanes or other types of issues. We know that's really important that we have diversity in the workforce, because when we reach out to people, whether it's a change in behavior that we're asking them to do, or to to follow a certain guideline, it resonates better when it comes from somebody that they can relate to, somebody that may look like them, that can speak their language. The last thing that I'll just quickly mention on that, and this is something that I think particularly here in New York City, because there are so many different people from so many different backgrounds and races and populations, that when we talk about the community engagement specialists that were part of the contact tracing apparatus here, there was a concerted effort to try to bring in as many people with diverse backgrounds that actually look like the community that we serve. And so the workforce that was developed here in New York City for contact tracers was actually one of the most diverse workforces in the nation, which was amazing. And a lot of them were hired from the hardest hit neighborhoods of the COVID-19 pandemic. So people could relate more to these individuals. They can have more trust. And one of the things I think that's really important, Margaret, I think that you also have noted, in some of our conversations, is the importance of trust. And as we look at building trust in humans to our institutions, to our elected officials, it's really, really important that as we foster this trust, that it comes from, a place of honesty and a place that people can relate to.
We also have a question from the chair of the nationwide Canadian International Council. We have 18, or is it now 19 office, Maureen O'Neill, who asks us, to what extent are women taking themselves off of the ladder to the top because of family obligations? Have there been studies?
Yeah, there is an interim report by McKenzie that has shown that more women than men actually have taken back in their career. So they've maybe taken a lower level position, or they've stepped down and gone from full-time to part-time because of issues of childcare support services, because things were going remote, and many other barriers and challenges. But you are seeing, by and large, more women do that than it is for men. I'm happy to share some of these reports after today's conversation. So these are reports that are interim. So this one came out, I believe, in 2020. And I think there's another one that's going to be coming out very soon. But it has shown that the impact has been much more significant for women. And I think it really just speaks to the predictability, right? And so when we look at developing policies, when we look at addressing many of these gaps and challenges, some of these are very predictable. It's by no surprise that you're seeing women being disproportionately impacted by this pandemic, especially when it comes to providing child or elderly care, trying to shoulder the burden both in the workplace as well as in the family. These are all predictable indicators, and it's really unfortunate that more has not been done, and that it wasn't part of actual policies, as we talk about the COVID-19 pandemic. And to give you just one example, when it comes to testing, right? You're seeing some reports by the United Nations where they're able to look at certain policies that were put together when it comes to testing, when it comes to vaccination, when it comes to masking, some of these core pillars of our COVID-19 response. And you're seeing that gender had nothing to do with any of these policies, but if you actually break it down to see who was affected most and who encouraged individuals to safer behavior, a lot of them were women, but that wasn't part of the equation. So it's really important that we get that data. And once we have that data, and that we're able to act upon it and make sustainable guidances and policies around it.
The question of who was affected also brings up the question of vaccine inequity. And Teresa Riziki Kabuha, and I apologize, Teresa, if I'm mispronouncing that, asks, first of all, says COVID-19 is a complex problem for all humanity. Her question is to know, are there processes planned for the census of the population already vaccinated, and presumably then so we know who's not vaccinated?
Yeah, that's a great question. That really speaks to vaccine passports and the like that other countries may employ. And as you know, in this COVID-19 pandemic, each country is so different in how they're responding to it. So you have one country that may have these, these vaccination passports that allow you to engage in certain services. So for example, here in New York City, you have Keys to New York or Keys to New York City. And what this program does is that in order for you to dine at a restaurant in New York City, in order for you to go to a museum or be part of some of these Broadway shows, you have an app that shows you that you're vaccinated, whether it's your first dose or second dose, if you've gotten your booster dose. So it shows you your vaccination status and then allows you to engage in that activity. And each country kind of has their own way of doing it. Some countries don't have it at all. Other countries have something that's much more stringent or much more relaxed. And so I do think that this is it's an important question. I don't certainly have an answer of what that may look like because it varies by each country. But I think as we look at this pandemic and as we look at future crises, I think it's an important question to address to make sure that we build a sustainable solution that works for everybody, but also make sure we have to look at it from a lens of equity and that it's not discriminating against anybody that may not have access, whether it's to vaccination or to many of these other preventative measures.
Teresa also asks a very interesting question that brings up the question of education and making sure people are aware of risk factors, choices they can make and how to balance. But she particularly asks for mothers, unvaccinated women. What would be the dangers for such women and their young children who may be exposed at school or whatever, and also dangers for fetuses for unvaccinated mothers? Could you comment on this?
So women that are pregnant are at higher risk of severe outcomes if they contract COVID-19. And not only are they themselves at higher risk, for severe outcomes like hospitalization, ICU level care, but their fetus or their child is also at higher risk, for preterm labor, for stillbirth, for other neonatal complications. And so by getting vaccinated, it helps protect both the mom as well as the baby. In fact, there are more and more studies and, the data is just piling up that shows that here, at least in the United States, that the vaccines that we use are very safe and effective. But, 6 out of 10 pregnant moms still remain unvaccinated. So there's still a lot of work that needs to be done to really show the positive impact of these vaccines and the impact of not being vaccinated and what it poses to you as a mom as well as to your child. So really important that people get information from trusted sources and that they look at these really great data points that are made available. I can't speak to some of the vaccines that are made available internationally. I can just obviously mention the ones that we have here in the US and the data that we have here, but globally certainly I know that is still a challenge.
I should mention that as a nonpartisan group, Our Canadian International Council aspires to give a voice to those without a voice, particularly marginalized, those who are fighting to have a voice. And this is especially important, therefore, to recognize the sacrifices of women in places like Afghanistan, Syria, and now, of course, the Ukraine, areas of post-conflict or very active conflict, in fact, war in the Ukraine. Could you comment on the special demands placed on women there, and also how we might be in a position to help, whether it's in terms of amplifying those voices from such places of conflict?
I think amplifying voices is certainly really, really important, and as well as providing the support that's needed. And so there's, I think, many different organizations out there that you can provide funding to that can go directly to many people that are looking for support services or for, leaving the country. So I think there's, and then I can certainly share some organizations that are doing some amazing work that I certainly donate to and that I'm part of, that I think, are really helping in this particular crisis that's happening in Russia and Ukraine. But I think first to your question earlier, the impact that it's having on women, as we look at the impact that displacement can have and war can have, and civil unrest, it has a direct impact to the health and well-being of women, as well as obviously to men and children, alike. But in particular, when we talk about women, you're seeing that the impact when it comes to healthcare services is pretty significant in ways that there's less access to healthcare services. So just for example, when it comes to reproductive and sexual health, they may not have access to contraceptives, they may not have access to the reproductive services that they need, whether they're pregnant and actually going for a visit. In many countries, for example, let's just say in the Middle East, I have a lot of colleagues and some family, and we see that, women obviously go to the clinic to seek healthcare services. But when, the COVID-19 pandemic, occurred and a lot of things went remote or were shut down, they weren't able to seek those healthcare services. So very similarly, I think as they relate to Ukraine, those healthcare services may not be available. They may be shut down, or they just may not be accessible. And so it has a direct impact on the health and well-being of women, as well as any pre-existing health conditions that they may have. So they may need certain medications and they may not have access to it. And so I think that there's many different impacts, both from a healthcare perspective as well as from a mental health perspective. I'm sure the psychological and mental health impact is quite significant. And I think those are things that we certainly need to make sure that we provide support services on.
We also have a somewhat related but very interesting question from Dr. Sheikh Bangura, who is the chair of our Africa study group within the National Capital Branch. And he asks, what would be your advice on best practices to avoid inequality of vaccines with respect to underdeveloped countries, especially in least developed countries, as well as within these countries with respect to women, since the gender imbalance there may be even stronger than elsewhere?
Yeah, I mean, that's a great question. And when we talk about, protocols, processes, algorithms that are developed, and various criteria that may be developed that try to prioritize who should have access to vaccinations first, that certainly doesn't work. Oftentimes, we've seen that here, for example, in the US, when the COVID-19 vaccines were first made available, it was first open, first to healthcare workers, and it was to those that are highest risk, and then it kind of went down from there. And you saw a lot of people, jumping the line, or, waiting when they should have gotten the COVID-19 vaccine first because, of their underlying health condition. So it's really hard to operationalize many of these types of processes or protocols. What you may envision may be very different than what, it plays out. But as we look, around the world and trying to address, the equity issue when it comes to vaccination. I think everybody knows there's a lot of work that needs to be done to provide more vaccines to countries all around the world. There certainly is commitment from some high-income countries, particularly here in the US, to provide more vaccines. And in fact, President Joe Biden's recent, national COVID-19 preparedness plan, has within the 4 pillars or the 4 goals that have been established is to make sure that we vaccinate the world. I just hope that there is much more commitment from many other countries to provide vaccinations, and not just giving vaccinations as the immediate need, but also building the capabilities in these countries all around the world to develop their own vaccines, and then to develop their own programs and processes to administering, and rolling out the vaccines. So I think there's a lot of work to be done, both in in delivering and making sure that they have the capability to develop these vaccines themselves, but also helping in that last mile. And I think that's where a lot of this also counts. So you may have a vaccine that's available, but if there's nobody that wants to take it, or there's less uptake, then you really need to make sure that you're focusing on developing robust vaccination programs. And oftentimes, especially in Middle Eastern or South Asian households, a lot of times it's the woman that tends to make a decision of whether their child is going to be vaccinated or not. And so to make sure that we educate women on the importance of vaccination, so that way they and their children can get vaccinated, is just really, really important. So there needs to be much more targeted education on this particular issue.
So we have one final question from Teresa, and then a comment from me with a request for comment by you. But Teresa asks, and it's really about vaccine hesitancy, and not only in the US and Canada, but for the whole world, including the region of Africa, where most of the population do not want to even hear about this vaccination. What can World Health do to convince these people? Because to her knowledge, and she's right, it would be a danger for humanity in future days. And this would, of course, be true not only for COVID, but other future pandemics. Could you comment?
Yeah, I think the one thing that I'll say is, can you hear me?
Yes.
Okay, for some reason it just, I guess maybe the presentation stopped. But what I'll say to that is, science and data only go so far, and you can tell people all the data and all the science in the world to try to convince them to get vaccinated. And a lot of times that's just not enough. People always have their own fact, right? So you provide a fact, and then they'll try to give you a data point that may not be based on facts, but it's a data point that they found. So there's always this kind of back and forth. And I think what is really important, and this is one thing I think that I have certainly learned in this COVID-19 pandemic, is the importance of bringing social science and behavioral science into these conversations, into making sure that we are talking to people in a way that they can understand and relate to. So science and data only go so far, but it's that human connection, that human trust that people often look to. And that's what helps kind of, sway them in the decision of whether it is to get vaccinated or whether it's not to get vaccinated. And so I really hope that we bring more social sciences into these conversations. And to give you just one quick example, and this is one of the programs that I run for our healthcare system, and it's Be a COVID-19 Vaccine Champion. And what this program is that we try to train and we educate more frontline communicators. And so it's not just healthcare workers, it's your mom, your dad, it's the youth, it's people around you, it's community members. And we take anybody that's interested and we have them go through this 1-hour training that we've put together. The first half is giving you all the science and the data about why it's important to get vaccinated and what are these vaccines. But the remaining 30 minutes I use to actually talk to them about how to actually communicate about the vaccines to other people. And we actually share effective communication strategies. It's not based on science of the vaccines. It's based on the social connection and how to develop that trust, how to use principles of empathy and understanding and being non-judgmental. So people have questions, but you shouldn't say that it's a stupid question. You should validate their question, validate their feelings, but then share, what works for you and maybe find a middle ground, right? So if there's a person that you both know, then maybe bringing that person as an example. Also using positive language. We've seen that using positive language resonates more with people than using negative language. So for example, what resonates more with people is saving lives versus you may die, right? Or your family versus your community. Your family is more something that they may care about, but when you say it from a community standpoint, they may not know everybody in their community, so that may not resonate a lot with them. So I would say bring social sciences and that personal connection and making sure that you have that trust and building that bridge is just really, really important.
This is so inspiring. And I have to say, your comments have really hit the mark in so many ways, both globally for our two countries, the US and Canada. Your remarks, for example, on child care burdens really resonated with me because here in Ontario, we are the only jurisdiction out of 13 across Canada that has not bought into a affordable child care program that would particularly benefit frontline healthcare workers, teachers, and those who have been so much affected by the pandemic. So once again, Dr. Madad, we are truly grateful for your inspiring and educational comments. Look forward to watching with great interest all the future heights that you will be reaching. I'm sure your career will go from strength to strength. And your remarks today, I think, will be so helpful to young women and also young men looking at careers in public service, especially in public health. With that, I'd like to turn the mic over to Hamid Georgiani for final remarks before we wrap it up.
Thank you very much, Margaret, and allow me to thank you, Dr. Madad. We are grateful that you took time from your busy schedule to come and meet with us and answer the questions that were presented. Judging by the number of questions and the type of questions we got, obviously there was a good satisfaction with the discussion and with the session. And once again, I thank you. And I would like to thank our audience for being with us and participating in this important conversation. And Margaret, I'm much grateful to you for taking the time to moderate this session. Happy International Women's Day to everyone. And again, it was a delight to have you, Dr. Madad, to be with us on this important day. And we celebrated in your presence and with your comments. Hope we have a better day for women across the world. And thank you so much for your comments and your advice. And I would like to take the opportunity once again to thank my colleague, Mr. Reed Grunewald, for his technical support, and the members of the board who have been supportive of our activities as a Middle East study group. Without any delay, now I would like to thank the audience once again and close the session. Thank you, Dr. Madad.
Thank you. Take care, everybody.